work in NHS. So for the other parts, it's important that you have some clinical experience, or otherwise you have to think in the way. You cannot think in the Indian way how things are done. So you have to do that, because there will be actors also there who will pretend to be patients, and you have to speak to them and all that. So that will I will discuss closer to the time. I think what you need to do is just read up about it and then come with specific queries, because it's just it's difficult to actually give a complete overview of the whole exam as such. But just understand that the courses that there are very useful. You have an entire series of these past tests, past questions, which are useful, and it's not a difficult exam at all. They just want you to be a gynecologist who is safe for the patients. You have to be safe. You have to know all their green top guidelines. So you need to know that by heart. The RCOG guidelines, they're called as the green top guidelines. And the third thing is that you have to be according to them, you have to be very empathic and very sympathetic to your patients and the way you interact with them. So that is important, which comes in part 2. One thing which is lacking in India is these statistical analysis and studies. And this is something that you may probably struggle with, and you will have to take special time out and study that, because that is there for part 1 itself. A lot of statistical analysis, and it is all there in the course reading material, which Satish will tell you. All the doctors have come together and put together a complete reading material guide for the MRCOG. So focus on that, because in your exam you will definitely have statistics questions. Now what I'll do is that I'll just go forward with the presentation. I'm not sure if Satish, can you see it on your screen? This is, we will just be talking about genital tuberculosis today.
Doctor, Mr. Satish is not available right now. Here. We are not able to use that PPT, doctor.
You can see?
We are not able to view that.
So to go about that then, open in my
screen, doctor, so that we can able to see.
Share screen. Now?
Yes, doctor. Now it's showing, doctor. We can view now.
Okay, so what we are talking about today is something which is very critically important for our country. It is very important for all the students to understand that tuberculosis is the number one major public health problem in India. You have to have a good understanding of all the concepts, and as far as the field of obstetrics and gynecology is concerned, genital tuberculosis is still very prevalent in our population, and you must understand some very basic concepts about it, and I will be talking to you today about that, and more relating to the field of infertility. Now, I think the noise is coming from Dr. Barry.
I have actually muted it, but it's still not getting...
Dr. Barrymore, there's something in your side which is giving the noise. Incidence of genital tuberculosis, it's about 2 to 10% of all the infertility patients in the Western data, and it's anywhere between 9 to as much as 50% in the Indian data. Now, genital tuberculosis is always secondary. You will hardly have 1 or 2% of cases which are primary, but they are more for theoretical purposes. It's always secondary to is somewhere else. Most common site of that primary is in the lung. How does the infection spread? It's a hematogenous spread. That means through the bloodstream, which is most common, or from the adjacent structures, like you can have it spreading from the intestine, or from the colon, or from the mesentery. Ascending means it comes up from vagina. Now that is extremely rare. It is almost unheard of. And what is the age incidence? It is 16 to 53 years. The maximum prevalence is in the age group of 25 to 35 years. It happens when a person gets a pulmonary tuberculosis. So the person gets an infection, maybe there is bacteria in the air and the patient's resistance is low. They get primary pulmonary infection in their lung. Now from lung there is a hematogenous spread which happens all over the body. And most of the patients, they have had a subclinical female genital tuberculosis which is not even diagnosed. So it is called a subclinical. Only when it causes all the damage and the patient then suffers from infertility, only then you find out that this person had genital tuberculosis. On average, it takes about 10 years. So there is a decade gap between the peak incidence of pulmonary tuberculosis and the peak incidence of female genital TB. We have very little data from India. So this is a lot of data which has come from Europe and specifically from Spain. So this observed about 1 decade gap between the peak incidence of pulmonary tuberculosis and genital tuberculosis. Now the descending infection, that is tuberculosis, is maximum in the fallopian tubes. Remember, if you're talking about female genital tuberculosis, in your mind, you just draw a picture of the uterus, the fallopian tube, and the ovary. Just close your eyes and in your mind, just picture the fallopian tubes, the uterus, and the ovaries. Now, if you're talking about female genital tuberculosis, remember that the tubes are 100%, not 100, but 101% involved. So always the tubes are going to be involved. Lesser percentage is the endometrium and least it comes to the cervix. Out of these tubes, 2/3 of the tubes, they have gross pathology. 1/3 of them, you cannot tell, they look almost normal, but 2/3 of them look gross pathology and they will not be patent, they will be blocked tubes. Granulomas, pathognomic feature. You know what is pathognomic feature? That is the classical feature of the disease. So for TB, it is what is called as the granuloma. You have studied this in your pathology, your TBS. So these granulomas are non-specific because the differential diagnosis can be either syphilis granuloma, sarcoidosis, or it could be Crohn's disease. So this could be an MCQ question for you, that if you see a granuloma, what are all the conditions that can be there? So you must know tuberculosis, syphilis, sarcoidosis, and Crohn's disease. Now, occurrence of female genital tuberculosis was clearly correlated with the economic and political conditions that brought about major reforms, and then there was a drop in the male pulmonary tuberculosis drop in 1961. But as you know, it takes 10 years for the effect to come to genital TB. So the female genital tuberculosis dropped in 1971. Now, why I am saying this is because understand that tuberculosis is closely related to the economy of a country. As the economy of Spain improved, the tuberculosis came down. So for India also, it is not just that you are filling the patient up with toxic drugs after drugs after drugs. Unless the entire country uplifts itself as an economy, you are not going to have that much of a reduction in tuberculosis as much we are looking for. So there are tuberculosis programs are very short-sighted because they are run by pharma companies. The company wants to sell their product. They are going to say, come on, load the patient with product. But it is important to understand that the example of Europe shows us that an economic change is essential. Now, the first 2 months after infection, what happens? You get a primary complex. Now, that is called as a Ghon's focus in the lungs. I'm sure all of you have heard of it. If you live in India, you're a doctor, you should know what's the primary complex, what is a Ghon's focus. And along with that, there is adenopathy. So usually it's the hilar lymph nodes that are enlarged. And in response to that, our body produces what is called as cell-mediated immune response. And the antibodies are formed. So that leads to a febrile reaction and a delayed hypersensitivity reaction. And once a focus is formed, there is a response by the white cells, which is a cell-mediated response. Along with that, there is also seeding through the blood and lymphatics into various organs of tuberculosis in 1 to 3% of the cases. Means patients, especially who have HIV or who are immunocompromised, they are on steroids, or they are little babies who are immunocompromised, they are at the highest risk of what is called as a massive dissemination or miliary tuberculosis or meningeal tuberculosis. 10 to 15% of the organisms always persist as live organisms, and they have the potential of reactivation. Whenever your immunity is reduced, so you are stressed, this is what reactivates it. Now, this is a slide from AIMS, All India. In India, we have the All India Institute of Medical Sciences, which has done the maximum research work on tuberculosis. And most of my slides and my presentation is from AIMS itself. So what happens is when you are exposed to Mycobacterium tuberculosis, there is an infection which could either progress and give you an active disease, or it could be a latent infection. Latent infection can either to an active disease, or it can just stay protected and just stay quiet for always. Now, what is the markers and correlates of protection? So this is just like the, what are all the stages you go through? Like either you develop latent, or you have early TB infection, or late TB infection, or severe TB infection, or just a disease after you're a cure or a relapse. So this is like a diagram which shows you that of people who are exposed, there will be some proportion who get infected. This is what happens in tuberculosis. These are exact figures. But see how many get microbiologically confirmed. You have hardly 20% or 25% that you will be able to confirm by microbiology. That is the most difficult situation that you will face in your practice tomorrow. You're going to all be consultants. You will be in practice sitting in front of a patient. The most difficult thing you will face is this, this beige colored and orangish colored, where the microbiology is negative, but you are strongly suspecting tuberculosis. Because in 20% of the cases, you will only be able to diagnose. So gold standard for diagnosis is a huge challenge in tuberculosis. The gold standard is a conventional methods which are called as histopathology or microbiology. In histopathology, you will see the Texila Edu granuloma, and in microbiology, you will see the acid-fast bacilli that will be growing in culture. But remember from the previous diagram, you will only have about 20% of cases diagnosed. You will have a very difficult dilemma when these conventional things are negative. So, how do you define female genital tuberculosis when all these conventional signs are negative? You don't get a culture where you can't see acid-fast bacilli, can't granuloma, and how can I say this patient has female genital tuberculosis? So in that case, you need to have a combination. So you have a combination of bacteriology, histopathology, means you will see something like your histopathologist will say, I'm seeing plasma cells. Cell feature that will point towards some kind of chronic infection or tuberculosis. And the molecular methods. Molecular methods discuss in greater detail, because these are right now the number one way in which people are diagnosing tuberculosis. Pick up very small amounts of DNA, I mean minuscule amounts. And of course, we have surgical procedures called laparoscopy or hysteroscopy, which will also help in diagnosis. Going through each of them, when you have the culture of Mycobacterium tuberculosis, it is a standard in adults, means it is a standard diagnostic test in adults, and lower limit for detection in culture. You at least 10 bacteria in 1 ml of sputum to be able to diagnose it in culture. And the culture is of two kinds. You have one solid culture and one liquid culture. Remember, the liquid culture is more sensitive than the solid culture. And a systematic review of 37 studies in adults have shown that most of the symptomatic cases, like you have 85% of symptomatic cases, tuberculosis is detected in the first sputum culture, while second and third specimens have an incremental yield of 11% and 3% respectively. Okay. And the non-commercial systems that are available means these systems are not used by commercial, they are used more in research. This is as a thin layer agar. This has a very high sensitivity to pick up 92% of the cases. and microscopic observation drug sensitivity. This is more for theoretical point of view. Even if you don't know this, it's not a problem. I just mentioned it because it is there. Now you have the microscopy of the smear. So what you can do is that actually somebody can cough, and you can take that cough on a slide and smear it on a slide, then look at it under the microscope and put the stain. So what is the stain most commonly used? It is called the Zeal-Nelson stain. You must know this. This is very important. Even if you're not doing microbiology, you must know the name Zeal-Nelson. Carbofuscin stain. There are other stains like ketone carbofuscin or a fluorochrome staining method. But Zeal-Nelson is the one that is used in all the textbooks mention this, and this is the one you should know. It identifies only about 50 to 80% of the culture positive cases. It's not at all good identification, but this is the best that we have now. So you see what kind of challenges we are facing. The kind of materials that we have are not so accurate to diagnose and to pick up. And not only that, the lower limit of detection, I mean, you need 100 organisms in every ml. Otherwise, Zeal-Nelson stain will just miss it. It will not pick it up. So this how many organisms, no, this you must know. This could be an MCQ question. How many organisms are required to pick up in culture, in Zeal-Nelson stain? Now, in the conventional method, in the solid media that I discussed for the culture, you need almost 12 weeks to culture it. I must know the name of the media. It is called Lowenstein-Jensen, LJ media. So you must know the name, the stain. You must know about this media, Lowenstein-Jensen or LJ media. Now we have a newer media called liquid media. Government setups are using Bactec. So it's the name Bactec. And the time which is taken is about 5 weeks, which is much lesser than 12 weeks. But even 5 is quite a long time. So the lacunae or the problems with the culture method or the conventional method or the gold standard method, the problems are that it takes forever. It takes so long. Patients nowadays want the result in 5 minutes. This takes 5 weeks. And there is no sense. You have to have at least 100 organisms per ml for it to pick it up. And say somebody has taken tuberculosis treatment or has half taken treatment and come to you and you want to see if it is still active or not. You cannot check in this because it is not useful. And because this is taking so long, so if a government of a country wants to use it for surveillance of its population, it is not possible because you will always lose the patients for follow-up. So the advances in culture. Now we have direct detection of tuberculosis, specific VOCs, the space of the liquid culture vials by using a combination of analysis. This is something which is, newer and newer research is going on. There's so much of a burden. So I want you to know that tremendous amount of research and work is going on. And this is one of them, where you have, tuberculosis bacteria produces some compounds. They are called as VOCs. Like whenever we spray perfume on ourselves, little dots of perfume, they are actually VOCs. So same way, tuberculosis bacteria produces some VOCs. And the VOCs are then, they try and pick it up by the culture, try to see if they can diagnose it. Now come to the one of the most commonly done and important tests, which is used to be called as the Mantoux test. Now it is called as the tuberculosis test, TST. So this test is actually the hallmark of a primary months after the initial infection. And in the small babies and infants, this less swelling that is seen, almost 5% sensitive and specific, and it has positive predictive value. So it is to how much tuberculosis is there in the community. And CDC is the Center for Disease Control and AAP is the American Academy of Pediatrics. So the recommendations in the US are that there should be a questionnaire which should identify high-risk children, and those you can use the tuberculin skin test. Right? But you know, as children, we are all vaccinated with BCG. We all have this scar. If you look at your shoulder, you will see a scar of BCG. That some dead bacteria are there in all of us. So there is a concern that when you do this MRCOG test, like how is MRCOG test done? Do you know? As the syringe that you can see a small amount of the same bacteria is introduced, the dead ones are introduced into the subdermal layer of the skin, and for 2 days positive. Or if there is nothing, I mean if there is no change, if it is just looking like it looked like on the day of injection, then it is a negative. So with the BCG vaccination, the test cannot be done, and in 80 to 90% of the cases, this skin test can be positive even 3 to 5 years after vaccination, which means that what I'm trying to say is that if you have been vaccinated and the test comes positive, it doesn't mean that you have TB. It could be because of the vaccine. That again is difficult to use tests now. Those molecular tests that I was talking about are what is called as PCR, or polymerase chain reaction test. And this is all, these come under nucleic acid amplification test. Say, American University. So first, it is university. University means this is a molecular method. Then American means it's affiliated to the US. So that comes as NAT, nucleic acid amplification. And then Texila. Texila is the name of the university. So TPCR, that is the name of the test. Tuberculosis polymerase chain reaction. Okay. So the heading is, it is a molecular method. In molecular method, there are many methods. This is a nucleic acid amplification method, which means that the DNA in all of us, which is the DNA of the bacteria, that is going to be amplified. Amplified means magnified. It's going to be magnified so that the machine can pick it up. Okay? And magnification is done by a technique which is called as polymerase chain reaction. So it is called as TB-PCR test. This test, you can use either the AFP smear, positive sample, negative sample. You can use the cerebrospinal fluid, CSF. You can use urine. You can use any tissue like endometrial tissue or from the uterus by doing an endometrial biopsy. You can use the pleura fluid. You use the fluid inside the joint. And there is something called gene expert, because nowadays there's a lot of resistance. So gene expert can detect rifampicin resistant drugs. That's all you need to know. So maybe if somebody asks you what is gene expert, just remember it is to detect resistance to drugs. Bacteria which is resistant to drugs, specifically rifampicin. Because if you're resistant to rifampicin, you're automatically resistant to isoniazid also. Now, this is just the sensitivity. You don't need to know this so much. You just need to know that it will pick up small amount of DNA. So you have to be very careful. If you are sending a sample from your skin cells will just drop into the sample, then that can also give a negative result. So to do this test very, very carefully, that there is no contamination, otherwise you can get a false result. So the PCR will detect only 3 bacteria. If you have just 3 bacteria also per ml of sample, it will be detected. And the gene expert needs 131 bacteria per ml of sample. Now, there are other tests which are called as the IGRA test. IGRA is interferon gamma release assay. Okay, so there's a lot of studies which have reported that there is a lot of variability in the test of the IGRAs, either due to manufacturing issue or whatever issue. So we have to run to test, we have to read it after 2 days. It is very difficult. It is easy if we have a blood test. You know, take the sample of the blood and tomorrow the result comes whether the patient is positive or not. But remember that blood test, IgG and IgM for TB is banned. It is banned by the revised National Tuberculosis Program. The only test which is not banned is this QFT, quantiferon. It is banned. It has logistical advantage over the skin test, TST. But there is a high rate of conversion and reversion. It suggests that it may not be an appropriate tool for surveillance. Now, when you're thinking in terms of your patient, but when our government of India is thinking, government of India has to think in terms of the very big population. So it needs to find tests which it can use to detect TB. So government of India tried to see if a blood test can be used. It is so easy just to take a blood be for surveillance. So there are ongoing efforts for newer diagnostic tests. Okay, maybe one of you will detect something in the future. I don't know. Now, what is the WHO policy on EGRAs and the skin test for low and middle income countries? It should be used for the diagnosis of pulmonary tuberculosis or extrapulmonary in the HIV positive patients. And the EGRA, if they are costly, they are technically difficult to do. So WHO is still saying stick to Mantu test, stick to your comparable skin test, tuberculin skin test. Now, the problem is that these tests, they cannot distinguish between the latent and active TB. So you have picked it up, but do you know if it is latent or do you know if it is active? You don't know. So it is very difficult to pick up. That is where your clinical judgment will come in. When you are seeing the patient, if you're seeing the patient is sick, you know it is active, then you're going to treat the patient. So just to summarize, for PCR, you need only 3 to 5 bacteria. For gene expert is 130 bacteria. For smear, you need 1,000 to 10,000 bacteria per ml. For culture, you need about 100 bacteria per ml. For myeloma, also you need about 100 bacteria per ml. Okay, this is the detection. This you all should know about. This is the same about quantiferon gold. You just skip it. How do you collect the specimen? So before you start any antibiotic, you must collect the specimen because all the antibiotics will affect the culture yield, and if possible, you should take it from the site of the disease activity. Like if you think that the fallopian tube is damaged or blocked, then try and collect it on the tube, washings of the tube. We can do this in laparoscopy. The endometrium, you can just take a biopsy from the womb, from the uterus. And if your patient has come, you're a gynecologist, don't forget that you're a doctor first. So don't forget that you must do an X-ray. Maybe she has a primary sitting there, which you missed. So you must always do an X-ray to check pulmonary definitely get better results. We have very poor sample collection techniques, then you cannot expect to be a good doctor for your patients and treat them. Now, laparoscopy, what are the findings? So what does tuberculosis do to fallopian tubes? It causes tubercles. You see those white colored small dots, there's caseation, there's dirty material coming out of it. Beading. It means the tube will look like a bead, like a necklace. So sometimes you see beaded appearance. So this is definitely tuberculosis. Probable. Probable means it could be an encystic fluid collection, or there can be dense pelvic peritubal adhesions, hydrosalpinx, tuberculin, mastic fibrous tubes, tubal block, extravasation of dye on the NTSC's salpingogram. Possibly means a possible sign for tuberculosis is mild or flimsy adhesions, dilated tortuous tubes, corn block, fibril agglutination of phimosis. Incidental means this is not related to tuberculosis, but it's just a finding that is incidental. Okay. Little test, remember that I told you AIIMS is the premier institute in our country. Now what they have found is there is this protein, okay, it is called as ADA, and ADA is the test for diagnosis of tuberculosis. So when you're doing laparoscopy, just take the washings of the peritoneum and send it to the laboratory for ADA. 100% sensitivity it has and 97% specificity. Adenosine deaminase, that is ADA. Okay, generally the value will be greater than 35 to 50. Told you need to misdiagnosis, mistreatment, and potential harm to public health. They are banned in India. I'm very sorry to inform you that a lot of these labs, like Lal Path Lab or any other path labs, they are still doing the psychological tests. But please, I request you, none of you, when you are in your practice, don't order these tests. They are banned in India and they are of no use. They are potential harm to public health and to your patients. The test that you should use most commonly is this PCR, the diagnosis of genital tuberculosis. These are all studies. What I'll do is this presentation I'll give Satish, so you can just go through all these studies so you can just figure out yourself. But basically, from the practical point of view, that is the PCR. So if you have a PCR positive, if you have smear positive, your solution is very easy. It is tuberculosis. But let me tell you, in clinical practice, you don't have such simple scenarios. You're going to have very difficult scenarios. So you have a NAT positive, the smear will be negative. Use your clinical judgment. If you think the patient has tuberculosis, give the patient treatment. If NAT test is negative, smear is positive. Now this is very strange scenario, because remember, NAT only needs 3 to 5 bacteria and smear needs 100 bacteria. So if the smear has picked it up, how is it possible that NAT has not picked it up? It can happen. And because there are a lot of inhibitors to NAT. For example, if you're taking an endometrial biopsy, the blood which is there in the endometrium, that itself is an inhibitor for NAT. If you're taking a sputum sample, if the patient has little blood, that is an inhibitor for NAT. NAT will not be able to pick it up in the presence of blood. So it could be because of inhibitors. Use your clinical judgment, you can still get the patient tuberculosis treatment. Clinically, you feel the need. And if both are negative, these are the guidelines which say that if both are negative, it doesn't say negative. I mean, see, it says clinical judgment, means if you have no test which is positive, still if your clinical judgment tells you, yes, Dr. Kavita, this feels that this is tuberculosis, Dr. Kavita will give the treatment, because the diagnosis is so difficult. Now, the tests are not very reliable. Now, what happens during pregnancy? Now, many years ago, a very provocative question was raised. Is pregnancy actually a helper to phenomenon? New concepts of pregnancy say that pregnancy is nothing more than an inflammatory immune response. Means pregnancy is actually an inflammation. So, it is many years ago, this question was raised. Yeah. I thought that is a phone from Texila, so I picked it up. So there is a evidence that it could be a T helper 2 phenomenon. That so in unsuccessful pregnancy, you get the helper 1 kind of cells. Immediate pregnancy loss. So if our body's immunity shifts towards TH1 type, then that can explain pregnancy failure. And this is what happens in tuberculosis. The immune system balance shifts towards TH1. So that could also be one of the reasons why people with tuberculosis don't get pregnant. These are the immune reasons. And it's a very good study. I think it's about the PCR test, which you can read. And there is a new advance on the PCR, which is called as the RNA test, which PCR detects DNA. Somebody thought, let us detect RNA. So this is the messenger RNA. Now RNA, the advantage was that if you get RNA positive, then it is live infection. If you get DNA positive, it can be from a live bacteria or dead bacteria. But if you get positive, 100% this is live infection. So the whole concept started very good. All of us clinicians are very excited. Now we have mRNA test. Of detection with 100 bacteria per ml, it is a marker of viability. So only when you have intact or live bacteria in the sample. It is not as sensitive as DNA PCR, because DNA you can get 3 to 5 bacteria. But the problem that came with mRNA was that it was extremely sensitive. So it used to die by the time the samples reach the laboratory. You have to process it within 1 hour, and it wasn't possible to do that. And you have to store it at 2 to 8 degrees. So we couldn't do that. So all these things cause problem. Then somebody else with reverse transcriptase PCR, RT-PCR test. So this was also again had some problems. So try and understand that genital tuberculosis is paucibacillary. Pauci means it has less bacteria. So the culture sensitivity is lower. The specificity is very high. So the consensus is that culture should only be used, and these are just images from the lung granuloma. So the take-home message for you all is that always you should look for pulmonary tuberculosis when you have extrapulmonary tuberculosis, because it has implications for isolation contact testing. Now, although the molecular methods are very good, but as of today, culture is considered to be gold standard. DI-PCR is like a signature. It's like the TB bacteria has signed, I was here. It's like a signature of the tuberculosis bacteria, and there is a strong cell-mediated response to tuberculosis, and that interferes with implantation and interferes with pregnancy. Now, the expert test is yet to be evaluated, but if it comes, then it is for rifampicin resistance, and it will be more of a sign for active disease. The IGRA test, do not use it for diagnosing active tuberculosis. Why we need to know active? Because these are the patients who need tuberculosis. 1/3 of India's population has latent tuberculosis, and if everybody had infertility, India wouldn't have a population problem today. The 1/3 of people simply would not be able to reproduce. But that is not true. So that is in that 1/3 population which has tuberculosis, you have to pick up the subset that is active tuberculosis, because that is the subset who will benefit from the treatment of tuberculosis. So each patient, after you start the treatment, very important to follow up after initiation of treatment. Thank you. Thank you, everyone.